Hello, and welcome everyone to another episode of Pulm PEEPs. Today, we're excited to bring you another in our series of rapid-fire journal clubs. We're going to be discussing the FIBRONEER-IPF trial, the anti-fibrotic Nerandomilast in IPF that was published earlier this year. I'm also excited because of two great guests we have returning to the podcast today to help us think through another paper in the ILD space. First, we're being joined again by recurring guest Robert Wharton, who's a pulmonary and critical care fellow at Johns Hopkins, and whose voice you may recognize from episodes on the Impulsos of the Stellar trials. Robert, thanks for joining back.
Hey, Luke. Great to be here again. Good to see you.
And next, we're also thrilled to be joined again by Nicole Ng, who you also may recognize from our earlier episode on the Impulsos trials and from IPF more broadly, our discussion there. She's an assistant professor of medicine at Mount Sinai Hospital and is the associate director of the Interstitial Lung Disease Program for the Mount Sinai National Jewish Health Respiratory Institute. Dr. Ng, thank you for joining us.
Thank you, Luke and Robert. It's a pleasure to be back here again and speaking on this exciting topic with you guys.
Yeah, this is an interesting paper, and I think it caused a little bit of a stir too, as I understand it, when it was first presented. And so I'm excited to break it down for folk here and now. Robert, before we get too into the weeds and what happened, can you tell us a little bit about what we need to know going into our reading of this paper? What's the background info we need to know?
Absolutely, Luke. I think what's important to know is that the treatments for idiopathic pulmonary fibrosis remain limited. We have nintedanib and pirfenidone, which provide modest reductions in FVC decline and may reduce exacerbations. But the cost is some pretty significant GI side effects, other side effects. And these treatments were subsequently shown to extend the entity of progressive pulmonary fibrosis in the INBUILD trial and are now seeing widespread use in practice, but we still have a lot of work to do. The FVC decline in IPF is not stopped, and there's a high degree of morbidity and mortality associated with it. This trial is exciting because it's got a new kid on the block, Nerandomilast, which is a preferential PDE4B inhibitor that has both anti-fibrotic and immunomodulatory effects. It showed promise in a phase 2 study that was published in the New England Journal in 2022 with no FVC decline in the treatment arm. And so this is the follow-up phase 3 trial, and we'll talk about a little bit how that was constructed.
Yeah, Dr. Ng, is there anything else you feel like we should know going into this paper?
Yeah, thanks, Rob. I think that was a good background to where we are now. I agree, we don't have any treatments to reverse or stop the disease, only to slow FVC decline, meaning patients will continue to progress. The phase 2 trial results were very encouraging and exciting to suggest that potentially we could have something that could finally halt FVC decline and stop disease progression.
All right, Robert, tell us a little bit about what they did. What happened here in this paper?
Absolutely. This was an industry-sponsored, double-blind, randomized, placebo-controlled trial at 332 sites in 36 countries. Like other trials in the IPF, PPF field, the primary endpoint was change from baseline in FVC after 52 weeks. They did an analysis with a mixed model for repeated measures, which kind of smooths out baseline imbalances and covariates and creates greater statistical power. They had a key secondary endpoint, which was the time to first acute exacerbation, hospitalization for a respiratory cause, or death over the duration of the trial. The data analysis was performed by statisticians at Boehringer Ingelheim, who sponsored the trial, and they had central adjudication of the diagnosis of IPF by imaging review, as well as guideline concordant diagnoses by a multidisciplinary team.
Yeah, I always appreciate when they're, especially in this space where it's so nuanced, making final diagnoses. I always appreciate when they're explicit about how they're making those, the central review of scans and things. You've talked a little bit about how they were thinking about the patients in the trial. Who ultimately was included in this one?
So these are patients with IPF, and using the imaging criteria that I described, again, central adjudication review. They could also be included if they had a indeterminate CT pattern and also some sort of a cryobiopsy or a surgical lung biopsy that was consistent with the diagnosis at the local site. They excluded a couple of notable groups, so liver dysfunction, which included transaminases or bilirubin elevations on labs or a diagnosis of cirrhosis, advanced CKD with a GFR less than 30, and some cardiac comorbidities, hypertension, greater than 160 over 100 in the last 3 months, an MI, CVA, TIA, or end-stage angina in the last 6 months, and notably psychiatric comorbidities, so like suicide attempt in the past 2 years, suicidal ideation within 3 months, or severe depression. And this is based off of, as a corollary to the side effect profile of other PDE4 inhibitors, namely roflumilast and ensifentrine, which carry warnings for these psychiatric conditions.
Yeah, I appreciate you just pointing that out. I feel like that stuck out to me because I think it's not true for other anti-fibrotic trials. One of the benefits of having a different mechanism of action is maybe it'll be more effective or work differently for our patients, but also has a slightly different potential side effect profile. So I appreciate you calling out those exclusion criteria. Who ultimately ended up in the trial? We've talked a little bit about what they were looking to include or exclude.
Yeah, their table 1 is over 80% male. The mean age is 70. About 2/3 former smokers, and the mean DLCO was 51% predicted. This was similar to Impulsus, which was the earlier trial of nintedanib in IPF. And most of the patients were on background anti-fibrotic. So 45% of them were on nintedanib and 30 to 33% were on pirfenidone. In terms of severity of illness, the mean FVC was 2.8 liters or 78% predicted. And Dr. Ng, I was hoping you could expand a little bit on how this is comparing to other trials in the field.
Absolutely. So Impulsus was with nintedanib and the Ascend trial was with pirfenidone. These trials were both done more than 10 years earlier, published in 2014. So most of the baseline characteristics, as you mentioned, in terms of sex, age, smoking status, they were pretty similar, as you have mentioned. A significant difference was that patients in the older studies on Impulsus and Ascend, they had a median time since diagnosis of about 1.5 years, compared to 3.5 years in the FIBRONEER trial. So you may think the patients in the FIBRONEER trial were sicker, they've been suffering from this disease for a longer period of time, but I think it's more because the landscape of IPF has evolved significantly over the past decade. And I suspect the rationale for the longer duration is multifactorial, but likely driven by earlier diagnosis, which represents lead time bias. So if you look at other parameters such as PFTs, despite the longer time since diagnosis, FIBRONEER patients had similar to higher FVC and DLCO values.
Oh, that's really helpful context. And I feel like fits with what I'm admittedly in my relatively short time as a pulmonologist. In my experience, I feel like people get so many more CAT scans than it feels like they did even 5 years ago now. And I imagine we're just catching folks a little bit earlier they get a CT of their belly and there's something at the base now, or nodules for lung cancer screening and we find some interstitial abnormality.
Absolutely. I think that's definitely true that we're seeing more incidental diagnoses of ILDs. And that's why we have this huge area of interstitial lung abnormalities that is also being unpacked as well.
And for sure, the ILAs that I still have not graduated yet, so I have time still to learn what to do with them, but
we're all still learning.
Yeah. All right. So Robert, do you mind telling us a little bit, what did they do? What was the intervention?
Yeah, this was pretty straightforward. So they had about 1,200 patients and they randomized them 1-to-1 to Neradomilast 18 milligrams BID or 9 milligrams or placebo. They stratified the randomization according to background anti-fibrotic use. First of all, before going into the actual results, we'll always look at the consort diagram to help us understand how patients flowed through this study. There were discontinuations in all the trial groups, so about 70 out of 390 in each group. Most completed the 52-week observation period. And upstream of that, a pretty good proportion of the patients who were assessed were randomized, which is reassuring that the study team wasn't cherry-picking patients that they thought would benefit. And so for the primary outcome, there was about a 60 to 70 milliliter difference in FVC between the placebo group and most of the higher and lower dose groups, which was significant at an alpha of 0.05. This is a pretty similar effect size to the phase 2, except that the baseline decline in FVC was higher, such that Nerandomilast didn't halt FVC decline as we thought it might based on a phase 2 trial. Some other notes about the results is a drug interaction with pirfenidone and Neradomilast, such that the patients who were receiving background pirfenidone needed the 18 milligram dose to be effective.
Thank you for walking us through that. The drug interaction portion is really interesting. I know, Dr. Ng, when we were talking about this paper earlier, this was a thing that you had some thoughts about, and in particular, their figure 2, which folks listening at home alone can take a look at this to follow along with us. But would you mind sharing your thoughts on how this drug seemed to interact with pirfenidone and so with the dosing of nerandomilast?
So I think it's very interesting. So when I first looked at figure 2, it looks like there's a clean dose-dependent relationship such that the nerandomilast 18 milligram had the lowest change in the FEC, followed by the 9 milligram and then the placebo. But I think that this relationship is driven primarily by the effects of the interaction between pirfenidone and the 9 milligram of nerandomilast, because of that interaction rendering it ineffective and therefore artificially attenuating the effects of the 9 milligram dose, because the 9 and 18 milligram dose appears to be pretty similar. If you look at the other groups of patients, such as the patients not taking background anti-fibrotic therapy and those taking background nintedanib, so, patients not on pirfenidone, the differences between the 9 and 18 milligram doses, there was no difference between those two groups.
Yeah, that is really interesting. And to your point here too, at first glance, I don't think I initially appreciated why they had reported this, but now that we've talked to it more, I'm glad they did. The authors actually measured plasma trough levels of nerandomilast at steady state, and folks who were on pirfenidone had about a 50% lower level than others. And it's a point well taken. I think the 18 milligram dose seems what I have seen folks using, but it does make me wonder whether the 9 milligram dose works too. All right. And so, Robert, would you mind telling us, we talked a little bit about the primary outcome, but I know they looked at some other things too. Can you walk us through some of their secondary outcomes here?
Yeah, and this is important because their key secondary endpoint, again, was this time to event analysis of first acute exacerbation, hospitalization for a respiratory cause or death. And there was really no benefit seen, no harm seen, but no benefit seen to Neradomilast, which was fairly disappointing. This was a more patient-centered endpoint. And there were really no improvements in any of its components or in the proportion of patients with a large decline in FVC or DLCO. And I'll kick it back to the two of you. I have my thoughts, but why do you think it might be that we didn't see any improvement here?
Yeah, so these secondary endpoints are not common, and so that's why the composite was used. I mean, we need large sample sizes and long durations of follow-up to detect such a difference if present. A limitation to the study was that these events were not centrally adjudicated. There was no difference found in the composite or in the individual events in the IPF trial, but in the FIBRONEER-ILD trial, there was a trend favoring nerandomilast in the same key secondary endpoints, particularly with mortality. And more recently, pooled analyses of the FIBRONEER-IPF with the FIBRONEER-ILD trials did show a nominally significant reduction in the risk of death by 59% in those on nerandomilast 18 milligrams versus placebo.
So it sounds like you're an optimist. You think that if we extended this out, if we had all the patients, we would show some more significant patient-centered endpoints. And
I think so.
And it also makes me think of, by corollary to our earlier discussion about Impulsus, where they have this pooled analysis showing a reduction in acute exacerbations when you have enough data. I think that's the optimistic reading, and then the pessimistic reading would be that it truly doesn't affect anything other than FVC.
Yeah, I am cautiously optimistic that as we go forward and we get more experience and data with this agent, that hopefully we'll see some signals towards benefit in some of these things as well. I think FVC decline is important, but it's a space where I think getting a win in one of those other things would be pretty meaningful. All right. So we've talked a little bit about kind of the efficacy of the drug, but I think it's also helpful, especially on the topic of anti-fibrotics that notoriously have side effects. Thinking about the adverse events here, Robert, how did folks tolerate this?
We expected side effects in this trial, and they were common in all the groups, including the placebo group, but there weren't any more serious adverse events or fatal events or things that led to interruption of the trial regimen in the treated groups. The most common side effect is diarrhea. It occurred in 41% of the overall high-dose group, and then in the folks who were also taking nintedanib, it was as high as 62%, which seems unsurprising to me. Dr. Ng, did you have anything else to add about the side effect profile?
Yes. So I would add that most of these cases were of mild diarrhea that was manageable. So expectedly, with Nerandomilast, those taking background nintedanib, they had the highest rate of diarrhea at 62%. Otherwise, about a quarter of patients developed diarrhea, whether they are on background pirfenidone or nothing. The higher dose of the 18 milligram did lead to more diarrhea, with 26% versus 17% without background therapy. But I would highlight, most of these cases were mild. In patients who were taking nintedanib, 13% of those on the high dose and 2% of those on the low dose had to discontinue treatment because of the diarrhea, and only 1% of patients needed to discontinue that on Nerandomilast 18 alone. So in summary, much less diarrhea compared to prior anti-fibrotics, especially nintedanib, and when present tends to be mild, manageable, and not necessitating discontinuation of therapy. Modifying factors are dose of Nerandomilast as well as concomitant anti-fibrotic use, but overall fairly well tolerated.
Yeah, that's great to hear. I think one other nice safety signal to call out here, just given that it was part of those exclusion criteria we mentioned, and theoretically could be a risk, I should say, of Neradomilast and not the other anti-fibrotics, is there was actually no difference in the rates of vasculitis, depression, or suicidality between any of the groups either.
And I agree, the adverse events of special interest were not more common in the treatment arms.
And so, Robert, we've talked a little bit about safety and efficacy. Can you speak to any of the quality of life outcomes for folks? Because we know that's also been a sticking point with some of our anti-fibrotics as well.
For sure. Here, the results for health-related quality of life were truly neutral. That not in any subgroup was there any significant difference. And the other thing that was disappointing was that it declined across every metric in every single subgroup, just reflecting how serious of a disease that this is, and we need better therapies.
So unless we have a disease-modifying treatment that is able to reverse or improve the underlying scarring, patients will continue to progress. And unfortunately, we won't see meaningful improvements in health-related quality of life parameters because they aren't getting better.
Yeah, and I would argue that's reflected here. It did slow progression, but people still did progress. And like we've mentioned, none of those measures of quality of life improved, which is a victory still, in that it's an effective tool, not as maybe as robust an outcome as we maybe hoped for based on some of the earlier like phase 2 trials. And so, Robert, we've talked a little bit about the nitty-gritty. I'm curious, taking a step back, how you think about this paper and the results overall.
So just to summarize, we have a decrease in the magnitude of FVC decline without any evidence of benefit in any other meaningful outcome, including mortality, exacerbations, health-related quality of life. So then we have to wrestle with how much does this FVC decline matter? To put this effect size into context, this is about half the reduction in FVC decline seen with nintedanib, so 65 mils per year. And some of the benchmarks that I read about were that 5 to 10% decline in absolute FVC over a year is associated with a hazard ratio of 1.34 for mortality, and a decline of more than 15% carries a much greater hazard ratio of 6.1. So we are hoping that the reduction in FVC decline will eventually translate to a patient-important outcome. And I'll turn it over to you all. I mean, do you guys think that is worth it? Is that something we should be pursuing right now?
Yeah. So I think it is. I might be biased, but I think it is. I think the effect size still is clinically meaningful, especially as we know that patients with IPF, despite treatment, still progress. So anything we do that can further slow down disease progression is meaningful. And while it's tempting, it would be inaccurate to compare the absolute differences in the FVC, whether with Ascend, you can say that was roughly 200 cc's versus Impulsus, roughly 110 compared to FIBRONEER. Even in the Ascend and Impulsus IPF studies that occurred within the same time frame, the patient populations were quite different. The baseline characteristics of patients in the Ascend trial did have lower FVC and DLCOs than that of Impulsus. So I actually like to look at the placebo groups in trials because it gives you a look at the natural history of the disease course and how patients recruited into the study at that time were doing without intervention. The FVC decline in the placebo groups were about 400 cc's in Ascend, 2 to 240 cc's in impulses 1 and 2, and 150 cc's in FIBRONEER, which has the lowest rate of decline. So perhaps patients in the FIBRONEER trial were less sick, as we mentioned before, because of the differences in the PFT parameters and rate of FVC decline. So I'd attribute these improvements to, like we said earlier, diagnosis, lead time bias, but also improvements in standard of care, that we have anti-fibrotics, referral to pulm rehab, use of supplemental oxygen, management of comorbidities, etc.
Yeah, that is really helpful context. And I do think, to me, these are still compelling results. I think it seems in my mind to fit kind of a piece with the other anti-fibrotics. I am curious, I know we can't quite compare them head to head, but I am curious, Dr. Ng, how in your mind, how this kind of fits in context with some of the other trials, whether for the other agents, I should say.
Absolutely. And this is the question everyone's asking. And short of a head-to-head trial, we would have to consider these to be relatively similar, and we can't say if one is better than the other. I would say within each of these trials, the intervention did lead to a relative reduction in FVC. This is hand waving, maybe around 50%. If you consider the numbers in Ascend, the difference was 235 versus 428, and Pulses 110 versus 200 to 240 cc's, and FIBRONEER 70 versus 150 cc's if you're looking at the no background therapy group. One additional point I wanted to bring up about figure 2 is that if you focus on these placebo groups, once again, the change in FVC in the overall population was 180 cc's. So when you stratify it based on background of anti-fibrotic, the decline was lowest in those taking nintedanib or pirfenidone at 190 cc's compared to those non-on antifibrotic therapy at 150 cc's. In other words, at first glance, it almost looks like patients who are taking antifibrotics had a greater decline in FVC than those non-on therapy. At first, it didn't make sense. I was also considering the FIBRONEER-ILD trial, where the same trend happened. On background nintedanib, it was a drop of 180 cc's versus 150 without background therapy. But here it made more sense because patients in the FIBRONEER-ILD trial, they had PPF, progressive pulmonary fibrosis, and they were selectively chosen to have progression based on FVC and or imaging and symptoms, despite antifibrotics. But here in the FIBRONEER-IPF trials, documented progression is not a requisite. But ultimately, I do think patients on antifibrotics in both studies were more likely to have advanced disease than those not on background treatment, what we call channeling bias. I think this is supported by data in the supplementary appendix, table F3, which is suggestive that patients on background antifibrotic were likely thicker with a longer time since diagnosis, lower PFT parameters, and increased use of supplemental oxygen. I'm not sure that the differences are significant enough to yield the differences in the FVC outcomes we saw, but I think it does indicate that channeling bias is likely playing a role.
Yeah, that makes sense to me. I think I was also a little taken aback that at first glance, it seemed like the folks who were on therapy did worse than folks on placebo, but I think the way you've framed it, I could find pretty convincing that it's more that the people who were already doing worse or had more advanced disease are the ones who are going to come into this trial on therapy, especially since they weren't being selected, where everybody was progressive as a requirement to be enrolled in the first place. That makes a lot of sense to me.
I think those are really important points. And I guess that begs a question of where does that leave us now? What are the gaps in the field? And specifically, I was wondering what you might think about or how you might think about first-line therapy in people who are being considered for Neradomilast, because the trial itself doesn't necessarily stipulate that you have to start someone on another antifibrotic first, or should we be starting Neradomilast first? How are you thinking about that, Dr. Ng?
I'm still thinking about it. So short of head-to-head trials, we can't say which medication is more effective. In IPF, I would say all 3 antifibrotics are fair game. My approach would be a shared decision-making process with patients. I probably favor Nerandomilast more for several reasons. One thing we haven't discussed is that we don't need to do labs. This is huge. For patients, for providers, we don't have to bring them back after a couple of weeks and then do labs every 3 months. And so I think that's a huge win for Nerandomilast. Secondly, GI side effects are significantly better with Nerandomilast than with nintedanib. And other considerations in terms of use, so pirfenidone is used 3 times a day. Some of my patients really don't like doing that. And so all of these little things matter. And so typically I would have this discussion with the patients. And I think this also leads us to the next question of what is our approach to managing these patients if they're taking background therapy or if they're not taking background therapy. Would you do upfront combination therapy or would you do add-on therapy? So I generally favor add-on therapy because when a patient has side effects, you don't know which one it's from and you just have to take a guess as to which one you'll peel back on. But it does slow down the process to get patients on maximal medical therapy. So I think similarly in this space too, I also have a shared decision-making process and discuss the options to patients for single anti-fibrotic versus combination anti-fibrotic, as well as the different permutations of this, because I think the patient's preferences are really important. Some patients feel okay and they really don't like taking medications, can't convince them to take anything. And then on the other end, you have patients who want to be as aggressive as possible and will take everything at once. And a lot of patients fall in between them. So I think that shared decision-making is really key.
Yeah, I love that. I feel like more and more as I go through fellowship, the theme in pulmonary in particular, where we don't have the luxury of the 20,000 patient trials that the cardiology gets, is shared decision-making. I feel like where these episodes always end. So thank you for reminding me of that.
Patient-first approach.
Yes, exactly. So this has been a great discussion. Thanks for bringing the paper to us, Robert. As we wrap up here, I'm wondering, what is your big picture takeaway from the FIBRONEER trial? What do you want to leave our listeners with?
Yeah, the top line result that I'll carry in my head forward is that Neradomilast is a new tool in our arsenal to slow the progression of IPF. Importantly, worked alone or in combination with other antifibrotics with a favorable side effect profile, but it didn't improve mortality, exacerbations, or quality of life.
Yeah, I love that. Nice, succinct summary. Dr. Ng, similarly, is there anything you want to make sure that we take away from this conversation or from this paper?
In summary, I would say Nerandomilast, as Rob has mentioned, was effective as monotherapy and as add-on therapy in patients already taking background anti-fibrotic therapy who have idiopathic pulmonary fibrosis. The recommendation is to start 18 milligrams for all patients with idiopathic pulmonary fibrosis. In those who incur side effects, namely GI, dose reduction to 9 milligrams can be considered in those who are not taking background therapy or already taking nintedanib. But in those who are taking pirfenidone, dose reduction is not an option due to the drug interaction with Nerandomilast, rendering the drug ineffective. A huge benefit, though, with Nerandomilast is that lab monitoring is not necessary compared to the traditional antifibrotics, which is really important for our patients. And while we still don't have anything to reverse or stop disease progression, I think we are moving in the right direction. As I alluded to in the podcast last time when we discussed the Impulses trial, I do think the management of ILDs will require a multimodal approach akin to many other complex diseases, from diabetes and hypertension to respiratory diseases such as asthma and COPD. Nintedanib and pirfenidone slow down disease progression. The addition of Nerandomilast slows this down even more. There continues to be numerous studies that are underway to continue to push the boundaries further towards more effective treatments. Other trials have shown promise in phase 2 trials that halt FVC decline and even potentially improve it in trials such as the Elevate and Whistle PF trials. So more to come, and hopefully we'll have the opportunity to meet again with even more exciting updates.
Yeah, I would love that. Careful what you promised, Dr. Ng. You're going to find yourself very busy.
Problem to have.
We would love to have you back on, both of you back on later in the future. All right. Well, thanks everybody for listening. Thank you to Robert and Dr. Ng for joining. That's a wrap for today's episode. I hope you all enjoyed it at home, and we will see you again soon for another episode.